We will be getting started in a few minutes. Yeah, welcome everyone. While we're waiting, feel free to add your name, city and state, and the institution you are affiliated in the chat box. Thank you. We'll start shortly. All right, everyone. Welcome to our last session in the series of weekly virtual presentation today. Thank you so much for joining us. And we're going to start in just a few seconds. We just wait for people to get on. All right, so thank you so much for joining us for our Massachusetts Oral Health Equity Virtual Summit. Today is our last session of the series of weekly virtual presentation. Feel free to get to add your name or type your name, the city and the state you're from, and also the institutions that you are affiliated with in the chat box so that we know where you are all from. So my name is On Bui. I'm the coordinator for the Oral Health Equity Project at the Department of Public Health in Massachusetts. And today I'm going to be the moderator for our presentations. So to start, we have some housekeeping items. Everyone going to be muted open entry to minimize background noise. We'll take questions at the end of all presentation. So feel free to enter any questions by entering in the Q&A function located at the bottom of the window. As you know, our webinar today will be having CAT reporter as well. So feel free to turn on the closed captioning by hovering over the CC icon at the bottom of your screen and click show subtitles so that you can see the captions for today. All these presentations are recorded and it will be shared and posted on the Massachusetts Department of Public Health Oral Health Equity webpage. If you need CEs, you will need to present here for the entire an hour and a half and also complete the evaluation that will be emailed out once the presentation has ended. So now, before we jump into the presentation, I have a poll question to see who's in the room. So just bear with me, let me pull it out. Feel free to fill it in so that we see who else in the room and who participates with us today. And so far we have 70, 50% right now. Just wait for a few more seconds. 50%. Great. Awesome. We're at 75% now. I'm going to close the poll right now, and I'm going to share that so we can see. Good. All right, I'm going to share here. As you can see, we have 34% who are dental professionals and 16% who are health educator. We have 11% who are community health worker, and the rest would be medical professional, ER providers, and WIC. So welcome all. Thank you so much for joining us today. So before we start, I would like to introduce our presenter. First, I would like to welcome Rodrigo Mantori and Kay Hampton, who will be presenting on activities of the Oral Health Equity Project. Rodrigo is the Deputy Director of the Office of Health Equity, and he brings over 18 years of public health experience developing, implementing, evaluating HIV/AIDS, emergency preparedness, and substance abuse programs. Kate is the FE for the project and is responsible for supporting the Office of Oral Health by conducting oral health surveillance and program evaluation. Rodrigo and Kate, please take it away. Thank you.
Thank you, An. And hello, everybody. It's a pleasure to be here to present with Kate on some of the work that we've been doing for the past 5 years as part of the Oral Health Equity Project. So Kate is going to be handling the slides for the both of us. Please feel free to enter any questions you have in the Q&A. We will be addressing them after the presentation at the end. And what I can say about the Oral Health Equity Project, next slide please, is that for a little bit of background, is that it's funded through the U.S. Department of Health and Human Services Office of Minority Health. And when they released the grant, the specifications of the grant required that we pick a particular health issue and justify why we were focusing on that health issue, and then to identify two what they called hotspots where we wanted to pilot our interventions or our project. So what we found in Massachusetts, reviewing a whole bunch of data, is that oral health was one of the Healthy People 2020 leading health indicators where Massachusetts had not demonstrated improvements over time. If anything, we were seeing that the trend was actually in the opposite direction and there was a lot of work to do. So that's why we chose oral health as the topic. And then we reached out to the Office of Oral Health at the Department of Public Health and engaged with them in a little bit of brainstorming of all the things that are going on, because there's so much programming going on around oral health, in particular, how to engage people in oral health. Where is there an opportunity for us to do something to complement what's happening already, so as to not duplicate efforts? And the other thing, the other kind of guiding principle for choosing oral health in these two communities is that the Office of Minority Health wanted us to identify communities that had lots of diversity, racial and ethnic diversity, and where we had documented access to care. So the services are there, but for some reason there are barriers to access. And so we selected Worcester and we selected Holyoke because they fit the bill. These are large urban communities in Massachusetts, Worcester in central Massachusetts, Holyoke in western Massachusetts, where we know that there are plenty of service providers, but where we also know that there are lots of barriers to access. Next slide, please.
Everyone, and thanks, Rodrigo. So I wanted to, kind of going off of what Rodrigo was talking about, give a little bit more context on the data behind how and why we chose oral health as a focus here in Massachusetts, and why we chose the two communities that we're focusing on, Worcester and Holyoke, and also how we're measuring our progress over time. But first, this slide talks a little bit more about why oral health in Massachusetts. So in looking at the data here that we have in our state, you can see significant inequities in access to oral health care for Black and Hispanic youth. The data on this slide are from the Massachusetts Youth Health Survey, or the YHS. The YHS is the Massachusetts Department of Public Health's surveillance project to assess the health of youth and young adults in grades 6 through 12. And we ask oral health questions on the YHS every other year. So the data shows that significantly fewer Black and Hispanic middle and high school students have been examined by a dentist in the past 12 months compared to white youth. And this is unsurprising given the numerous structural barriers that many communities of color face in accessing oral health care. And poor access to oral health care among these children means fewer preventative services, higher rates of undiagnosed and untreated dental caries, and poor long-term oral health outcomes. So addressing these factors became a focus of this project. And then to focus even more, we chose two pilot communities of Worcester and Holyoke, Massachusetts. And we chose these communities for a couple of reasons. One is that Worcester is the largest city in the state without community water fluoridation, which, as we know, is an incredibly successful preventative measure and has a major impact on oral health outcomes. And in addition, these communities have some of the largest proportions of Mass Health Medicaid recipients in the state without a dental claim in the 12 months before the project. And Worcester and Holyoke also have a higher proportions of Black and Hispanic youth compared to the state average. And so this slide just shows the percent of youth in these communities are generally higher than the state as a whole also. And these maps, for those who are joining us from out of state, give you a sense of where Worcester and Holyoke are located. And with that, I'll turn it back to Rodrigo to talk a bit more about our overarching project goals and focus over our 5 years.
Thank you, Kate. And so we identified 2 primary goals for the project. The first one is to increase the number of Black and Hispanic children ages 0 to 14 who are accessing oral health services. And ideally by finding them a dental home, because we know, as I mentioned before, there's a lot of activity going on in the oral health sector, in the oral health space, but some of that, for example, the programs that are based in schools do not necessarily result in the child having a permanent dental home, if you will. So that was one of our goals, is to connect children who had not been to the dentist with a dental home. And then the second one was that, as Kate and I have been saying, what we're choosing to do in these 2 communities as a pilot, that we would be assessing and doing a continuous quality improvement throughout the process to eventually come up with something that we felt could be scaled or replicated across the state. And so part of that meant that all of our findings, all of the data, all of the lessons learned, we would be compiling, producing reports, fact sheets, briefs, and then presentations, and developing trainings, and then also so that we could, and actually this summit, this presentation today is part of that. As part of year 5 is how do we then disseminate the lessons learned for replicability and for sustainability beyond the scope of the grant. So if you don't mind, Kate, I'm going to share some of those products that I was just referring to. So for example, we produced these community oral health profiles. Not sure if folks can see that. Oh, there we go. Whoops. Jeez. I'm having a tough time managing this. Hold on. I apologize. Maybe this will work. Okay, so hopefully folks can see that. So we have community profiles that we developed for Worcester and for Holyoke, looking at challenges or barriers to access to dental care, to oral health. And the way that we did that was we did community engagement work, where we actually conducted interviews with key informants, folks from the provider community, both the dental health provider community, as well as we hosted information sessions and conducted key informant interviews and at PTA meetings, at the YMCA, through after school programs, and a whole bunch of other settings to collect data to to try to identify where there might be some challenges as well as opportunities for improvement. All right, so back to you, Kate, in terms of the slide sharing.
Yep.
All right, and so through all of this community engagement work that we did, we, like I said, attended community meetings. We engaged with over 500 families. We collected over 100 oral health surveys. We conducted key informant interviews. And some of the findings worth sharing here that help guide some of our work was that even though most people we engaged with agree that children should be checked by a dentist when they start getting their teeth, many disagreed or did not know why, or didn't know that children should actually be going to the dentist that early on. Massachusetts did produce the perinatal oral health guidelines a few years ago, and we've been trying very hard to promote them amongst both the pediatric medical community as well as the dental clinician community, because some of the findings there and some of the recommendations there explain that children should start going to the dentist, and actually pregnant women should be going to the dentist and getting their cleanings, and that most parents actually wait until children are 3 or more years old, and we start seeing issues and problems because we wait that long. And so, for example, pediatricians do not necessarily refer parents to bring their children to the dentist until much later, or dentists will say we don't see them that young and things like that. So we follow the perinatal oral health guidelines. We also found that nearly half of respondents reported that they didn't realize that overall health actually depends on oral health, that actually cavities in baby teeth can actually impact overall health. And some of the barriers that we were able to identify that people were describing in our encounters was that transportation and time limitations and dental cost and the difficulty of getting an appointment were some of the most frequent challenges or barriers to dental care. So we used all this data to try to guide our efforts to make sure that, well, if we know that these are challenges, whatever we start implementing or trying to put in place should work with some of these limitations. Back to you, Kate. Oh, is this mine?
Yeah, I think
well? Okay. All right. So what did we do? So year one, like I said, was it starts with all this community engagement work. And then starting in year two, we were expected to establish partnerships so that we could start implementing our interventions across a variety of systems. So we engaged with public schools in Worcester and in Holyoke. We engaged with early intervention programs, since we knew that a key area that we had been missing was that 0 to 3 years of age. We felt that early intervention programs would provide a good in to that age group. We also engaged with community health centers, both Family Health Center of Worcester and Holyoke Health Center, because health centers have both dental providers and pediatric providers, and we felt that that would be a very easy way to create a linkage there between pediatricians and pediatric oral health providers. We worked also with WIC. We obviously worked with Mass Health, because one of the things we found is that most of the children on Mass Health, because they have dental health coverage, you would presume that the challenge of cost or coverage or finding a provider wouldn't be an issue, but these are issues that folks identified. And in fact, we found that data that we looked at from Massachusetts was consistent among Mass Health clients. And Mass Health is the Massachusetts version of Medicaid. So we found that even having coverage and even having providers who take that coverage was that even among that population, almost half of children had never been to the dentist. We also partnered with clinical consultants and providers who became our advisory committee. Rosie Wagner actually presented in one of the sessions, one of the earlier sessions as part of this summit. And then we put together a coordinating team that included folks from the Office of Health Equity, also folks from the Office of Local and Regional Health, and also folks from the Office of Oral Health.
So thanks, Rodrigo. So this slide gives you a little bit more of a sense of what those partnerships look like on a diagram version, what types of activities that they have chosen to work on as part of this project, and sort of how they interact with each other. Because this is what we're really trying to do here, is build a system that all kind of synergistically works together. So on the top here, you'll see early intervention, Holyoke programs. So those include Holyoke Early Intervention and Holyoke Public Schools. And both of those refer in different ways to Holyoke Health Center, particularly to the community health worker who was hired there in their dental clinic. And on the bottom, these are the programs in Worcester. The system looks fairly similar. In addition, there's another partnership with WIC that's facilitated by Family Health Center. You'll see different types of lines on this diagram, and those are basically just different types of referrals. So the solid line, those are what we're calling direct referrals. So basically one provider is calling another and making an appointment either via the phone or an electronic referral system directly. And the dotted lines are what we're calling indirect referrals. So a family is being provided with the resources that they need to make an appointment with a dental provider, and they then follow up with the recommendation at their next appointment, and whoever referred them follows up to make sure that they actually went. And you'll see kind of on the left and rightmost columns a little bit about the activities that our partners were conducting, including some staff training, education, oral health assessment, referrals, and follow-up. And I'll talk a little bit more about those in the upcoming slides. So Rodrigo mentioned a bit about our overarching objectives. Here are 3 specific project objectives in terms of evaluation. So for this project, we identified 3. The first was to engage community members and establish partnerships by the end of the first year of the project, which is what Rodrigo talked about a few slides ago. The second objective was to increase the % of Black and Hispanic youth age 0 to 14 years who were seen by a dental provider in the cities of Worcester and Holyoke. And the goal was to increase that by 10% over baseline over the course of the project. And we measured that using our Mass Health Medicaid data. And the third objective was to disseminate results and develop a statewide oral health equity plan. And as Rodrigo also mentioned, part of that is what we're doing here today, the Summit series. So on this slide is our logic model. I know it's a lot of information, but it details a little bit more about what we're looking at in terms of how those objectives translate to our project activities and eventually to our long-term outcomes that we're hoping to see. And I'll go into more detail again on these in some later slides, but in general, we did a lot of work around knowledge and referral skills of those who are working in our core service systems with young children and adolescents. And our core service systems included early intervention programs, public schools, WIC, and our community health centers. We also wanted to help identify some of the barriers that patients were experiencing in terms of screening and treatment services, and to figure out ways to get around those. So this is our evaluation design. We conducted both a process and outcome evaluation. Our process evaluation was mixed methods, so used both qualitative and quantitative data. We felt that this design was particularly helpful in understanding the experiences of those doing the work, so the qualitative kind of helped complement the quantitative data. And then just a little bit more specific specifics on our process goals for each of our partners. So with EI programs, early intervention programs, we were really looking at improved knowledge among oral health staff, pre and post aid training that we conducted with them. So we conducted a pre-post training survey and knowledge assessment to go along with that. We also measured an increase in the percent of children who received a referral from EI staff and actually completed that appointment by the time of their 6-month EI follow-up. With community health centers and the dental community health worker that was working on this project, we looked at the percent of children referred who kept their appointments or no-showed, and that was referred to the dental clinic facilitated by the community health worker. And just a note, if anyone saw Tuhan Nelly's presentation a few weeks ago, you saw some of those results in more detail. And for public schools, we were really looking at an increase in the percent of students who were identified as not having dental care in the past 12 months, as documented in their school health record system, which is called SNAP. And again, our overarching quantitative outcome measurement goal was to increase the percent of Black and Hispanic youth in Worcester, 0 to 14, Worcester and Holyoke, 0 to 14, who saw a dentist in the past 12 months using our Mass Health claims data. So here you can see our baseline Mass Health Medicaid data. This is at the beginning of our project in 2015. This shows the percentage of youth in Worcester and Holyoke eligible for Mass Health who had a dental visit in the past 12 months by age and race and ethnicity. This was helpful to look at by age because you can see that the percentage of patients who had a dental visit in the past 12 months varied. This helped to inform our strategy for which service systems to engage, since the strategies for how to reach 1 to 2-year-olds is a lot different than the 10 to 14-year-olds. So this slide shows the trends in the Mass Health data that we tracked over the project. So 2015 to the most recent, which was available, 2018. And of note, we were able to see that dental visits among Black non-Hispanic youth age 0 to 14 increased by 3% in Worcester and 4% in Holyoke over the course of the project. And we are still collecting data on that, so we'll have updated numbers. But it is important to acknowledge, I think at this point, that the project focused on some smaller pilot projects across our different service systems. And the goal was really to develop effective models in those settings within community health centers, early intervention, and public schools. And these are 2 very large cities in Massachusetts. So ideally, to see more population change over time, we would look to expand these pilot projects even further. So looking to use these models in more health centers, more schools, et cetera. So now I'll go into a little more detail on the different pilot projects. So starting with our early intervention or EI programs. So we worked with all of the EI programs in the Worcester and Holyoke area. They focused their work on children mostly under the age of 3. At the beginning of the project, we worked with them to determine what the best way was to make changes that would allow them to incorporate oral health into their workflows. And in talking to them, they identified 2 main issues. One, that staff were not sure what the kind of comfortable with the recommendations on when a child should be told to see a dentist. And the second issue was that families were not comfortable necessarily sending their young children under the age of 3 to a dentist. Many times families couldn't find a dentist in their area who would take a child under the age of 2. So the first thing that we did with EI programs was to conduct a training at all 4 EI sites in Worcester and 2 sites in Holyoke. And the goal was to orient them on the oral health guidelines, the perinatal guidelines, as Rodrigo mentioned, for young children, and the referral procedures around how to make an oral health referral when they identify a child who need to be seen by a dentist. We also equipped the staff with resources to provide to families. One of those things, it included a list of providers in their area who actually saw patients with the Mass Health Medicaid insurance. This graph shows the pre and post survey results of that survey. you can see that 43% prior to the training reported that they were very comfortable knowing when a child needed to be seen for preventative dental care, and that increased to almost 70% after the training. And we'd also conducted a survey, an additional survey, to follow up 6 months after the training was completed, and found that the number had remained consistent. So that was encouraging. Okay. So in addition to the training with EI staff, we also incorporated some oral health questions into their workflows. EI staff conduct a series of appointments with the families over time. The first visit, where a lot of questions, healthcare questions are evaluated with the families, is often called the initial intake visit. There's a similar follow-up appointment 6 months after that initial intake visit where those healthcare questions are reevaluated. At the start of the project, there were no oral health questions in those evaluation forms, so we worked with the directors to develop questions and an efficient workflow to go along with those. And since there's so much already covered at these appointments, and there are often a lot of competing priorities both for the families and the staff, we wanted to make the process as easy as possible. So EI staff asked at the initial intake, has the child been seen by a dentist in the past 12 months, providing that they had teeth? And if no, the families were provided with a list of dentists in their area and were encouraged to make an appointment. Then at the 6 month EI follow-up, if they were told to make an appointment, the EI staff would ask again if they ended up going to that appointment or if they needed any further dental care. This was all documented, and the chart shows that this chart shows of the original subset of children who were encouraged to make an appointment at their initial intake, which ones actually followed up with dental care. And that percentage increased from 27% to 50%, which was our goal. So as I mentioned, we also collected a lot of qualitative feedback from all of our partners throughout the process to better understand these results and refine our process along the way. EI leadership and staff outlined, in terms of successes, the importance of the Oral Health 101 training that was conducted at the beginning of the project. And that training helped staff that they felt feel more comfortable about oral health and discussing that with parents and helping address any barriers that came up. And in addition, adding the oral health questions was also helpful as a reminder for the staff to ask about oral health. As I mentioned previously, there's so much that goes on in these appointments. It's just helpful to have kind of something to remind them to ask the question. In addition, the list of dentists in the area that accepted MassHealth was also important in being specific about what recommendations they were giving families. And in addition to these successes, there were also a lot of challenges, many of which we're still working through. One is that staff already collect a lot of information at these visits, which makes an additional data point difficult to collect consistently. And also there's a lot of staff turnover, which means that any trainings have to be incorporated into new hire protocols. And then one of the biggest challenges are kind of the mixed messages from medical and dental providers. So there are many times where EI staff would recommend a child to be seen by a dentist, but then their pediatrician says they don't actually need to be seen yet. Which is doesn't necessarily agree with the guidelines. So here we see more of a role for dissemination of our perinatal oral health guidelines. So informed by these results, our next steps, we're working on a couple things. One is that we've created an online module version of the Oral Health 101 training, and that should be released fairly soon, and that'll be incorporated into EI new hire protocols. And we're also working to get oral health into existing EI forums, not just in these pilot communities, but across the state. Okay, so moving on to our next service system, which is community health centers. We worked with 2 community health centers in Worcester and Holyoke, and we hired in each of those one dental community health worker. For those of you, again, I mentioned earlier, but for those of you who attended Tuha and Nelly's presentation a few weeks ago, this is going to be a little bit of repeated information, but I think it's still important to mention. And if you haven't seen that presentation, it'll be available as a recording and sent out to everyone along with all of the presentations at the end of this series. So look out for that. But to summarize that great presentation that they they did. Community health workers are fairly new to the dental setting. So the goal for this component was to see if what has worked for other community health workers and other clinical settings would also work in dental. The main goals of the CHWs were to act as a connecting point for all our other service systems that we engaged and to help reinforce the importance of oral health, to address concerns, to facilitate referrals, and to follow up on appointments booked. The process goals for this project were to see an increase in kept appointments and a decrease in no-shows, which normally are around 35% for no-shows and less than 50% for kept appointments. The CHWs were able to increase the kept appointments above 50% as a part of this project, which was really great, and also to decrease no-shows from what was about 35% to under 14% recently, which is awesome. So we also wanted to hear from the experiences of the CHWs and what worked for them. The CHWs all affirmed that a key component of the success from their perspective is the trust that the families have in them. The families appreciated that they have a direct phone line of someone to call to get their questions answered. There was no waiting, that the CHW really understands their concerns. So these are just a few quotes from the CHWs who have worked on this project. And I'm going to highlight this last one here, that the patients were so receptive to the information that they then felt comfortable enough to tell their family and friends to go talk to her as well. So in terms of sustainability of this project, it is a little bit trickier. In order to continue the work in the dental setting, CHWs require reimbursement for their services. And for more of an explanation of that and some of the challenges around that, Tuha Nelly's presentation addresses that very well. So last but certainly not least, we worked with the public schools in both Worcester and Holyoke to build oral health into their environment and into their workflows. For this pilot, we worked with nurse care coordinators specific to dental who were hired for this project by the Worcester and Holyoke public schools. These nurse care coordinators were tasked with primarily with adding the oral health data point into their workflows. So adding a question on the last dental visit and dental home into the health intake / emergency forms that go out at the start of the school year. And then subsequently collecting that information in the school health record system, which is called SNAP, so that they could then pull a report to see how many students were in need of a dental visit. So the nurse coordinators then helped to determine the protocol for how to provide referrals to those students who were in need of dental care. In Holyoke, which is a little bit of a smaller school system, all the schools in the district participated in the pilot. And in Worcester, it's a much larger school system. 4 schools were chosen to participate in the pilot project. And you can see a lot of the project was focused on kind of getting the system to collect oral health data in place, and it's really challenging. So that is a major success of this project. And you can see some of the data points that have been collected so far on the left-hand side of the screen. So in Holyoke Public Schools, in 2018-2019 school year, they sent out 3,272 dental forms to students across the district and had an 80% return rate. 76% of those students had a dentist of record after a year of oral health education and follow-up. And in Worcester Public Schools, 2,134 students returned dental forms, and 31% of the students had a dentist of record. And again, collecting this data is a huge success. So some lessons learned from this project are included on the right-hand side of the screen. One of the biggest ones was the importance of an oral health champion, so identifying someone in the school, either a school nurse leader or a school nurse, that is crucial to ensuring buy-in and developing successful processes that are specific to that school system. School nurses have a lot of also competing priorities, so oral health must be something that fits easily into their current processes naturally, and who better to understand that than someone who is already in the system. And this is also especially important because each school is different, so not one solution necessarily is going to work for every school system. In addition, training is also important for school nurses. They found it helpful to have this information incorporated into professional development days, and also having nurses share their firsthand experiences at those professional development days was helpful in giving more of a personal connection to this issue. So having those nurses share that is helpful. And then, as I mentioned, data collection early and often can help identify opportunities for improvement and make sure that everyone's on the same page. And then in terms of sustainability of these processes, this is something that the public schools are continuing to work on. And they all have these data points built into their system already. And some of this, one of the things that is most important is finding someone who can build that data entry into their current job. So one of the recommendations that came out of some of our qualitative work was some of the schools are working with LPNs and CNAs who are already in their school system to help enter data during their free time. And so that is all I have in my presentation. I will turn it back. I think we're doing Q&A questions at the end. So anyone who has any questions, pop that in the Q&A, and we'll do our best to answer them at the end of the presentation.
Thank you so much, Kate. Thank you, Kate and Rodrigo, for capturing our project over the course of 5 years in 40 minutes. So again, all the questions will be taken at the end. I would like to welcome our next presenter, Ralph Fucillo, to deliver the closing remarks for our series, including opportunity for actions related to oral health equity. Ralph is the principal of the Cambridge Concord Associates, a mission-driven consultant practice based in Boston, Massachusetts. He works with a broad range of organizations across philanthropy, health, education, and community-based services. Ralph, please take it away. Thank you.
Thank you, Ann, and good morning, everyone. It's great to see on the chat some friendly names and some people I haven't met yet, but this is terrific. And I was so honored to be asked to provide some closing remarks, and we'll try to do that in enough time to leave with some questions and answers, which is the most important part of all of this. You know, I was disappointed at first when we couldn't meet in person, but seeing names from across the country, it sounds like Zoom facilitated something that we maybe couldn't have done ourselves. You know, we've learned a lot from our colleagues over the past few weeks, and I hope I'll be touching upon them in a way that brings it all together. But I couldn't start this session without just talking a minute, reflecting about how our lives have changed over the past few months. Not only the introduction of COVID into our world and the other dynamics that's so close to many of our hearts of people, you know, speaking out to and racism and division across our communities. I don't know anyone whose life hasn't been changed. And I guess I would call one other a moment, because you've been listening a long time. So many health dynamics are connected now to breathing, not just personally or just as an unconscious habit or in our yoga practices or, you know, in some intentional healing process around mindfulness or even in cultural rituals. I want to encourage you to take a breath, appreciate it, and also stand or stretch in case you've been sitting too long. So, you know, I do want to start with a little bit more appreciation for people who put the summit together and the information that you just shared by Kate and Rodrigo about the project itself. 5 years of work and dedication has been amazing, and it's the kind of information we need to know. It's the kind of practice we need to encourage with one another to bring our shared knowledge and experiences towards something greater. You know, we're getting people to a place of cultural competency with some of the early work that you heard in the summit and around the country. And most of all, we've learned that there's so much more we need to do. I call this sort of appreciation of collective wisdom. You know, I don't want to go by speakers by name, panelists by name, but just think about what people have shared with us in terms of our attention to language, our principles of interacting and relationship building, not only with our professional colleagues, but with our populations, communities, and patients. There are sensitivities that we've been instructed about and shared, and we really value the way in which people want to be spoken to, how vulnerable people feel, and know that there are some specific behaviors. Vaping was certainly a great presentation and an introduction, a reminder, those of us who came up through adolescent health and communications on how to do this. And of course, we've all been hearing so much about the importance of oral health during the early years, and including pregnancy. So I'm going to focus not so much on the data piece of it, which is the last item here, but on engaging the community. I think our collective wisdom, you don't need me to say any more about location, race, socioeconomic status, cultural. Our previous presenters have done that. What I do want to just emphasize through this is to make sure we use what we know, and to do that, to think about what we've heard so many times, whether people have said it explicitly or not, that there is this separation of the mouth from the body, and I'll talk a little bit about that later. But we have this opportunity, not just across the dental and medical profession, but sort of a broader health view of the professions when we hear about CHWs and others who can do that. So I hope I can share some ideas about a collective wisdom toward positive change. I want to start with a poll, and to do that, I need to go to this, and I'm going to bring up another poll. So this is purely opinion, okay? There's no right answer to this, but I wanted to get your sense of these 6 items, you know, whether is it lack of affordable, low levels of literacy, you know, personal behavior, shame, discrimination against, you know, certain types of patients, or is it the broader structural racism? So I'd ask you to go to your screen, make a choice. I know these are tough choices, and again, with no right answer. We just want to see what's on people's minds here. So a few more. Give people a chance. So yeah, I think we have a good return here. I hope everyone's had a chance to weigh in. I hope you can see the answers here. A few more choices. So there we go. So you know, it's interesting that no one shows shame, and maybe we can talk about that in the Q&A. But the other answers here are really aligned with, you know, people's perceptions and understandings, mostly perceptions of how we end up with some poor oral health outcomes or our disparities. So what I hope to do is to continue to frame oral health equity as part of the overall health equity. You can see that the different departments and leaders from DPH are working together on this, and Rodrigo gave a good overview of how that all fits together. I've been a big proponent of engagement of multiple stakeholders in this, and thinking about all the lessons we've learned from public health. You know, right now we're in the midst of a lot of attention on public health. I don't think I've heard on public media, TV, more experts, even the governor and other elected officials talking about how the importance of oral health is. You know, we have an example in our state where we've been getting everyday updates. Those people who are pushing for economic reopening, and thanks to Commissioner Burrell and Secretary Sutters and the governor and others, reminding people how important oral health is. So I guess I just want to say that in terms of thinking about, you know, building on this time where we've known about health disparities. We've been working on this for a long time, many of us, and we now have to continue to help those who are paying attention to us in a somewhat opportunistic way to generate priorities for future action. You know, I've been asked to identify which topics I would address, and I will talk a little bit about each of these, and at the end, talk about some things that we might do together in Massachusetts. So why is this the time for action? I'll say a little bit more about that. So the timeliness is often a factor when you're thinking about stepping forward. We are informed, not only through this summit. I know that we've had short sessions in some ways to keep us all connected in terms of the data and what we can do. But data drives decision making, as I just mentioned, in terms of policymakers and elected officials. And then this last one, I know is somewhat controversial to some people. I hope it isn't to too many on this call. Many of you have heard me say this over the past 15 years at least, that because we've been able to look at some root cause analysis about the systemic impacts and the gaps in access, disease prevalence, perceptions, I'm going to say all these words because they're important, the worthiness of the person and people, and then some norms of exclusion around across zip codes and some populations. I mean, these are real dynamics that people have told us over many years around why they are unable to access care. So to me, social justice is a frame. It is one that takes us beyond a concept that I'll talk about in a moment. So there are a lot of themes, and I'm not going to spend a lot of time on this slide, but I do want to call out two things. One is this idea that there are systemic issues in oral health, and that we know that our personal stories are important. I taught in Catholic schools for a long time in the early part of my career, and when people would talk about a previous generation about some of the behavioral practices, people would always have a story about what it was like to go to a Catholic school. Maybe you have stories about your own. But when it comes to oral health, everyone has a dental story. There's a lot more pride from some populations these days talking about Lukman cavities and people who have access and some sense of what I'll call economic and other access privileges versus the people who carry a lot of burdensome stories. And so I just call those two together. I'll say a little bit more about that. And I guess this is the part where how, all the sensitivities we had about language earlier keep us focused on why words matter. And, Matt talked about the Frameworks Institute and the work of Open Network and thinking through how the frame really is about people who meet locked doors. And that what we do as facilitators of change is provide keys and more importantly, open doors. So some of the thinking is to get oral health beyond people just thinking about their teeth and getting people more information that they can use to not only access to care, but to manage their own care. And then we do have expectations for health outcomes. People don't always connect how important the mouth is to the rest of the body. And they also don't feel that they often have a voice in the policies that advance oral health. We've seen that a lot of conflict over the past, I guess, 15 or more years, specifically about the dental workforce, for instance, that hasn't been resolved in everyone's mind. And health coverage, sort of Medicaid and Medicare dental coverage that has limitations when it comes to adults and older adults. So I just call your attention to the Frameworks Institute work that was published in 2018, and that title so revealing of unlocking the door to new thinking and getting some frames. So if you are involved in your community and you are trying to raise awareness about oral health, this might be a good resource for you. I do want to call attention to the fact that, we have lots of champions in, let me just stay on that for a moment, who, was pointed out from the project as an important piece. I hope I've been a champion with all of you for oral health, and I want to be sure that other champions have been named. I think right now we're all really happy that we've heard great news about Myron Alukian's health, and so I just call him out as a champion in Massachusetts and working on a lot of these things from the early days. So how do we think about shifting perception beyond the frameworks publication? And I want to just call your attention to a very simple set of comparisons here. So for people who think about this as teeth, I think people think about this as white, straight teeth, some implications there for some cultural dynamics we're experiencing. A lack of compliance, this is about people who don't take care of themselves. And then in a community setting, I can't tell you how many times I've been in community meetings where people say, I just expected I was gonna have cavities and pain. That's what everybody had, and it was just something that we had to do. You know, one of my other big oral health champions was the late Congressman Elijah Cummings, who frequently in our groups nationally and in DC would talk about his experience of you know, going to the medicine cabinet for yeah, I think he talked about turpentine and a cotton ball, which sounds just so excruciating and unhelpful. But that's how a lot of this was treated in some community and family ideas about how to just stop the pain because everyone had it. And then this other piece that has social implications about people who can't get jobs and who feel real sense of shame, maybe not about going to the dentist, but certainly about showing up with a missing tooth or unhealthy teeth. Now compare that for a moment to this idea of a health view of the body, and this is where, you know, there's no separation. You know, oral health, I mean, the mouth is part of the body. This is you know, somewhat of a bold statement, but the preventable disease. We've seen studies that talk about this as being nearly 100% preventable, and lots of different cofactors and multiple factors of getting to disease. So it's not a linear prevention, but it's a prevention. And then, you know, are there some ways in which we can help people think that, you know, it's not you get to a certain age and you lose your teeth, and you have bad gums and you're suffering and all those things that you see on TV, but that this is for your life, thinking about the health of your overall health through oral health. And then this idea of the presence of disease requires lifetime management. That's what we do with other parts of our well-being. And so if that's true, then think about that. Now, population and geographic indicators matter. This is our familiar phrase about zip code mattering more than genetic code. But I think this is really important when we think about how people can embrace a health view. So that leads us to this phrase that a lot of us in the field use of this oral systemic connection. It actually takes it a little bit beyond, speaking about words matter, but this is beyond medical dental. And I'll just let that sink in for a minute. We're not just talking about connecting primary care and the dental office or the dental suite. We're talking about oral systemic connection, very broad. And so when we think about that, we have to take it to what are those systemic constructs at every level, you know, personal system, health system, the community system, family system, community system, et cetera. And what are the dynamics that are challenging integration? You know, what's holding us back from this common sense view that the mouth is part of the body and we have to treat a whole person in a person-centered way. So what some folks have been doing, which I'll tell you about by name a little bit later, is, you know, organizing the systemic change so that we have a wide range of stakeholders, including people who seek care, people who are getting care. I've bundled them as patients, but I think you all know me well enough to know that I just mean people, you know, whatever phase they're in. And so an important part of the equation when you're thinking about what needs to change. It's not to say that people aren't still very nervous about this. The tensions remain about whose job it is to take care of certain things and to perform certain procedures, and that's good. We need good quality, and we need to have the cooperation and work through those issues. There are models of change that I might be able to talk about if we have time, where you're seeing not only education tracks for professionals, especially clinicians, changing, but actually some practice models as well. So the best news I have is that there's movement there, and that we're going to get closer to what we think will help more people. So given this audience, you know, I saw a lot of it is the dental profession, but I know some of you are public health dental, and I think you'll relate to this, and for others, this might be a part of a Q&A or a longer session sometime. But thinking through these stages of prevention or degrees of prevention as we talk about them, you know, we are really caught up in the payment models and in the care models around tertiary prevention. It's where we see and experience most of the problems, and it's where we need a lot of help. We also, I know that when I see some of our dental hygiene folks on the chat, and hello to you, you know, that it's this early identification of problems and trying to figure out how to help people with that self-management, such a critical part of what we're trying to do. But if you move up to the top, the first level, in other words, we're really trying to deal with it. That's why the systemic issues are so broad. We're dealing with quality of life and life conditions. We talk about them as social determinants of health. And where possible, we talk about the absence of disease and primary prevention, but we're really thinking about this. So I hope that, you know, I don't want to leave this slide up too long, but I do hope you ponder and reflect upon what are our opportunities to really eliminate dental disease. You know, for my colleagues who are clinicians, I'm not, I sometimes have to clarify that, you know, in some of the oral health meetings, you know, I think there'll always be enough, there'll be enough need for care in specialties. And so I hope that this encouragement toward primary prevention doesn't feel too challenging in terms of what are we going to do if everyone's healthy. We got some work to do, and this is one of those things that really does feel possible, but over what period of time and with what kinds of actions. So again, something to reflect upon. So continuing with the public health awareness, you know, we've had the two decades now. It's 2020, and Dr. Satcher, out of his office, issued the first report on oral health out of the Surgeon General's office. He did, you know, the commission paper talked about our sense of this being multidimensional. The public health lens on this, again, was not as familiar, given that even though dental public health and the oral health folks at APHA and MPHA have been at this a long time, it hadn't been articulated in this way from a national office in the way that it did. And it did, this was more than anything, at least in my read, was an identification of the population disparities, sometimes referred to as a silent epidemic. And it wasn't long after that that Dr. Carmona, as Surgeon General, was issuing the call to action based on the Surgeon General's report. And so we have, for those of you who are part of the oral health community, you know that Dr. Adams, Surgeon General Adams, is issuing. I think it's not so much referred to as a 20th anniversary oral health report. It is in process, and certain events of our times have probably delayed that into another, maybe even 2021. We just had an update on that recently, and it sounds like it'll either be late this year or early next year. So really just talking about it as the next oral health report out of the Surgeon General's office. Now these are the 5 actions that were called upon by the call to action. And you know, this might make sense to a lot of you, that awareness is important, evidence is important, promising practices as well, to try some new things, but also we needed to increase the science around oral diseases. And that's very important to what I was talking about in terms of the degrees of prevention. The idea of diversifying the workforce had different dimensions to it, not only racial and ethnic, but I think in terms of a sort of a who can help kind of participation. And then this last one that has to do with collaborations and partnerships, which is where I spent most of the time that I had as the president of the DentaQuest Foundation since 2006. And you know, so I'm taking this, a future slide is going to talk about the role of philanthropy and why an actor out of the funder world would go in the direction that we did. So building on that action 5, it's not just get a bunch of people together and focus and form partnership, but it's really understand where working together will make a difference. And this is part of my entry into the title of this session, Opportunities for Action. So invite others who are not only us, in other words, beyond the choir, the partnerships are for a broad range of health issues. We have our professional associations, we have our societies of those of us who can fit into those, but the broader range of people who can shape the future is really important. And I emphasize this common ground. We're talking about community engagement. We know there's a lot of, thankfully, a lot of diversity of thought around our tables, but seeking common ground moves things forward in a way that can be very productive. And I think that wherever we are now, I don't think we can go anywhere without having an equity lens. So I'm hoping that you bring that. So this is a quick, really quick checklist on terms of saying, well, so what is it about community engagement? So I think it's important to define it, say why we're doing it, how we're going to do it, maybe broadly at first, but not narrowing it down as you go along with agents of change and dynamics of change and timeline for change. So other health groups have done this. So I wanted to take a look at this, and I know certain people are on the phone who have worked in HIV and behavioral health, but think about the conditions we found when we were working on these issues. It's such a complex manifestation of the illness. We didn't even know what to call HIV in the very beginning. Certainly the disproportionate infection rate, overlooked in marginal populations, people demanded, because they had to, better care, better research and investments, both from the government and from, in some cases, pharmaceutical companies, in some cases, academic medical centers. But they addressed the social isolation and inclusion dynamics and said, we're going to do this together. And so the movement achievements, when you think about behavioral health and HIV, both still in process, I realize, but I'm going to just bring out some early successes, is that people got to the root cause based on evidence or made the evidence real. They tested things. So people came to consensus about what had to be covered and what care systems needed to do. This is a really important part, that both in HIV and in behavioral health, in HIV we had ACT UP, and in behavioral health we have NAMI, just as two examples of multiple levels of community response. And so the community-based methods that we used in both those health issues have paid off. We've got people, we now have people living with HIV in very different ways than before 1996. And this is all, at least in my estimation, due to the collaboration across all of the systems, including those who worked on prevention. So let me see if I can get this slide to work. So I said a word about being an actor in the oral health space, welcomed by many of you in 2006 to say, well, what do we do with the money and the resources we have? I really want to focus on this middle one we're calling about balancing charity and justice for the preference for social justice. So this is a very controversial piece in terms of staying away from things like advocacy, the lobbying for philanthropy. And we were really deliberate about being careful about that. Because on the one hand, when I started, we were funding a very important component of building oral health in Massachusetts. We were funding the community health centers who didn't have dental clinics. And we were funding one Head Start program in one part of the state and one Head Start program in another part of the state because of the mandate around an oral exam. Asking community health centers and Head Start programs and so many other school-based health centers to work together on this provided a root cause analysis, like why are we having together in our own communities so many difficulties? So over the years, philanthropy got organized. There was a sense of collective impacts and efforts, and we certainly were focused on funding what we could to foster sustainability. I kind of live by this thinking because I just don't know any other way. I think the inescapable network of mutuality is what we're all in. Who could say it better than Dr. King with talking about it as a single garment of destiny and how each of us relates to one another. And that's really the basis. I want to give you a chance to read all that. The interrelated structure of reality. I apply this to oral health, and our staff way back in the foundation at DentaQuest, we're able to codify this with many of you to say there are really 4 major systems in oral health that are at play with one another in terms of making a difference. And we don't have time to spend on each of these, but imagine if oral health was a key component of all health policy instead of something that groups had to advocate for almost in such a persuasive, almost begging way for people to pay attention to covering the mouth, similar to the missing dental benefit in Medicare. Imagine if we had oral health integrated into education and social services, and it wasn't a special grant that had to, include community health workers in oral health, but that they were a part of, integrated into the health system, and we knew how to pay for it, which is the funding being sufficient as we identify above. In care, we don't have the workforce we need. We don't have enough, or we don't have availability, affordability, et cetera. And then this other part about working toward primary prevention is, can we look at care based on evidence, prevention, disease management, and outcomes at many different levels. So I have to move a little bit more quickly here, but I hope this, you'll have this slide, you can study it, you can talk about, people have a suggestion at the end about how it can be used. So there are many ways in which we can get people to work together, inclusive of oral health, being inclusive of dental care, all the way down to thinking about our pathways to health equity. We've adopted, I know Sam and the folks in Rhode Island made reference to this in terms of the HESs and other ways that you've been part of networks, to say large-scale social change, which is what we're really talking about here, requires this cross-sector coordination. And yet we still see everyone sort of thinking about their own organizations, and that's not going to get us anywhere. So this exhibit out of a magazine from BC Center for Corporate Citizenship identifies the conditions for collective impact. It's a real simple way to understand it. And think about the middle section where this mutually reinforcing activities, if we all stay together and continue to work on this, we'll get the other parts right. So I mentioned some of the fabric of change agents earlier, and also Kate and Rodrigo talked about all of these being involved in the project in one way or another. So I'm going to move on to this. I was really pleased to be part of an ADA session in 2009 that built upon 12 different stakeholder groups, where we were able to form out of that over the next 18 months into 2011 to create the U.S. National Oral Health Alliance, which was completely focused on bringing people together to shape common ground. It was a precursor to the Open Network, which I know many of you are part of. So the encouragement about going forward is that people have organized themselves. So community health center, safety net people are part of NOAA. Some folks on the phone who formed the Interprofessional Oral Health Initiative on Oral Health, NIO. Sorry, it's there twice. The Open Network and Santa Fe group that I'm part of. And then of course the regional and professional associations, everyone working toward this outcome. So what should we be looking for? We should be looking for more networks that include awareness and action. I was pleased to be part of DentaQuest, and I'm not there anymore, so I'm not representing a conflict of interest here, but just talking about health providers, health systems, health insurers, developing systemic change models where they're bringing together how to reach into the community as well as to pay for the right things. The momentum and evolution is really all about us. And so we need some tools. We heard some maternal child health tools. We've heard the Rhode Island tools. We've heard some other tools, including what we use in the project. But this is a program that is operating. Some of the partners are the Texas Health Institute. This is a national project. You can look it up and get in touch with the principals on this. But they're really able to forecast. That's what I'm most impressed with, is starting to forecast based on some of the indicators that we're all familiar with on how to visualize what might be needed, and to do that through the stories. So I'm getting close to the end of my time here, and I wanted to say, so what should we do? What are some of the things that we should do together? So if you go back to my systems quadrant, I haven't seen anyone really get at least 2 of the indicators in any of those boxes into an operational model. people keep trying. I want to encourage people to keep at it. I also wanted people to look at this approach called precision public health. There was an article recently, I think in the California Dental Association journal, on precision public health for the mouth and for oral health. And this is a concept that precision, used in the healthcare system on precision medicine. But if we really understand what we're learning about the mouth in terms of technology, artificial intelligence, new ways of self-management, Bluetooth toothbrushes, all of those kinds of things, we're going to zero in on what are the right levers to promote this. So, we're still struggling on the oral health equity piece. Maybe we have to look at the case statement that we could develop around policy change. People are working on that in Open and other networks. And then lastly, if we were to do some organizing of our core elements, what would it look like for us to, sorry, went the wrong way here. What would it look like for us to develop an person-centered care system? And no offense to anyone in the dental profession, but what if that were to happen and you didn't have to take the lead? Maybe your pediatrician colleagues or your nurse colleagues and others appreciated how important the mouth is, and you could direct, you could coordinate, you could develop, you could share, collaborate, all kinds of ways of acting. So in summary, I think you heard from me a couple of key themes that are on my mind. Let's keep prioritizing primary prevention. Let's keep thinking about systems and systems change. Let's mobilize our stakeholders at the grass tops level, grass middles, grassroots, and let's really, for many more reasons than just oral health equity, let's think about entering in together this network of mutuality mindset that Dr. King talked about. I do offer you a good read on reducing oral health disparities. It was done in 2006 by a group of colleagues that I don't think anyone's on the phone from this group, but we sort of all know them. But it's a really sort of comprehensive document on that. So I want to leave our time for Q&A on, and I hope turning it back to you is the right move here. Thanks, everyone. It's good to be part of this.
Thank you so much, Raf. Let me just share. Yeah, thank you, everyone. Thank you for the presenter. Thank you, Raf, Kate, and Rodrigo for a great presentation. So for all those who have questions, feel free to type in the Q&A sections, and we're going to monitor now. I know that some audience already mentions that Raf have been going so fast for the last couple of slides. You're going to receive a slide deck when the presentation's complete. So you might be able to have some more information there as well. So we still have 12 minutes for questions and answers here. I have some questions already posted in the chat and the Q&A. Maybe the panelists can answer that. So the first questions could be, is the belief that baby teeth will fall out? And so why focus on them?
This is Rodrigo. So the question being, what is the reason that either parents or providers are resistant to referring children to see a dentist until they're about 3 years old? And actually, Ralph posted some of what I think are the most common reasons for people choosing not to engage in dental care. But I think that is the one that you listed in your question. The belief that these are baby teeth and they will fall out is one of them. But also shame, fear, if their pediatrician doesn't tell the parent that it's a good time to bring the child to the dentist, then it's one less thing that they have to worry about, and they would rather not have to worry about it, especially if, accessing a dental provider seems like a challenge already.
Yeah, I want to just emphasize that the limited view that this is all about teeth. There's a lot going on with the gums and pre-eruption stages that if the education were across, especially with pediatricians on healthy baby visits and others, we might see a little bit more of a connection to why that's important. Again, I'll leave it to the clinicians to say a little bit more why.
Yeah, thank you, Raf and Rodrigo. The next questions I have here could be, how did the first presenters overcome just plain fear of dental care in their project?
If the first presenters, you mean Kate and myself, the OHEP team, we listened. We listened to the community, and then when we tried engaging providers across various systems that work with children, from schools to CHWs and community health centers working in the pediatric setting, or dental health providers, as well as parents and anyone that we engaged with, we developed trainings for these providers. We listened to them when they said, I want to make sure that the information I'm providing, I feel comfortable providing, and B, isn't going to jeopardize the trust that I've built with these parents. For example, in the early intervention space, where children who may have complicated health needs really listen to their EI providers for their guidance on what services or what referrals or what needs there might be for parents to address. One of their concerns was, I don't want to refer them to the dentist and then have the dentist say, no, we don't see children this age. Or if the child has complicated health needs, trying to make a referral to a dental provider, but the dental provider feels that they don't have the expertise to address those health issues. So a lot of our training was addressing those fears that our providers, and not really fears, but concerns that our providers shared, that they knew were fears that their clients had, so that we could provide them with the information they needed to address those fears.
Thank you so much, Rodrigo. The next questions I have here could be, did you have to address language access as well as ensuring accessible dental offices for children with disabilities, both physical and sensory?
This is Rodrigo again. So for the Oral Health Equity Project, we had to be very selective in terms of what we felt we could do for the limited resources in terms of funding and money, and funding and time, to meet our grant deliverables. But also, we didn't want to replicate work that was already happening in other spaces. So we chose to focus on what we considered entry points or access points for dental care. We really didn't focus a lot of our energy on training dental health providers, or in looking at addressing some of the, I guess, the limitations in terms of what's accessible in the dental care space. But we know that obviously there's a limited number of providers that speak other languages. So we actually created somewhat of a directory of providers that we knew had expertise serving children with disabilities and complicated health needs, providers who spoke other languages. And we actually provided this directory to our OHEP partners, because that was one of the concerns that they had raised for us.
Thank you, Rodrigo. Another question here could be, how many dentists are currently licensed and practicing in Worcester and Holyoke? I ask these questions because this feels very much like the access problem we face with mental health, where there are psychiatrists out there, but one can only access them for care if they can afford to pay for it out of pocket. Is it an unrealistic objective to find ways to get dentists in the area to open their practices to more of the population?
I just want to say, this is Rodrigo again, that we have folks from the Office of Oral Health here, Brittany Brown and Matt Horn, who presented earlier on. And also Ralph, in terms of his role in the past with the DentaQuest and the DentaQuest Foundation, who feel free to chime in if my answer doesn't completely address this. But I tried to address it to the best of my ability in the Q&A. As far as the number of dentists, that data is available if we look at licensure data, if we look at how many dentists are licensed by geographic area. But the short answer is that there are many dental providers in both of these areas. As far as working with them to increase the percentage of clients on Mass Health in their patient panel or census. That is work that I know that DentaQuest and other entities, including Mass Health, have been doing with dental providers. Let's see, I'm trying to go back to the question to see, because it was a multi-part question. If there are other aspects of the question that I haven't addressed. Well, so we know that there are a large number of providers in these areas. We know that many of them do take Mass Health. They may have a cap on the percentage of clients that they have on their patient panel. We think, based on our work and interaction with folks in the both medical and dental space, that part of the challenge is that providers don't feel they have the expertise to address specific needs related to children under 3. So maybe some more training and more capacity building is needed in that space. Also with regards to language, with regards to disability, with regards to transgender, gender identity. But I think the principal barrier is that there's a lack of training with regards to the perinatal dental guidelines around why it's important for children to go to the dentist as soon as the first teeth erupt. So that is work that's happening right now to promote those perinatal dental guidelines. I'll add that it's not just about the children, it's also about pregnant women not accessing dental care and having fears around getting cleanings or getting treatment for dental care while they're pregnant. And this is a particularly risky factor for overall health, mothers and children, for infant mortality and preterm births. So it's another aspect of the perinatal guidelines that we're looking to promote at DPH.
Thank you so much, Rodrigo. Another question here could be, I grew up in Africa and was taught that wisdom teeth are to be kept and that they are for wisdom. My family still believe that. Are they for wisdom?
So Matt, do you have access to speaking, or do you want me to cover this? So I gave an answer to this on the Q&A that it's really varied opinions on whether third molars, which are referred to as wisdom teeth, should be removed. And it sounds like we've had some affirmation of that. You know, they get the name from coming into the mouth later in life, as Matt said, and generally providers aim to help patients keep these teeth if they're functional for chewing and able to be cleaned. Sometimes you hear about them getting removed for overcrowding, infection or decay, and other difficulties. So, and I'm not sure about other cultural meanings, but if you can keep them, then people keep them. It's really sort of a case-by-case situation. But we don't understand that they're for wisdom. It's just more the stage of life where they enter into the cavity.
Thank you so much, Ralph. So I think we have time for one last question here before we close. So early on was work done with dental providers to increase their understanding of Mass Health reimbursements for oral health and to increase Mass Health recipients in their census as well as reducing the wait time for patients to get an appointment.
Well, certainly the reopening, certainly during the reopening, this is a problem. I've had several calls over the past few months of people in really tough situations trying to find a way to get care. And there have been some, access to emergency, but some of it is how people manage their appointments, but we're also in a moment, I don't know if that was the question behind the question, but it's really a tough time in terms of people getting everything that they want from dental offices now, but they are reopening and we're seeing a lot more engagement.
Yes, this is Rodrigo. I'll add to that. There was a question specific to that I think was related to COVID, and it's that right now there's guidance for dental providers, particularly in community health centers, not to see patients unless there's an emergency need for care. And so that is the case, and we're looking at, like Ralph said, reopening. But the other question about how much work is happening to make sure that providers understand the need for increasing the number of people on Mass Health, reducing wait times, and maybe providing a better understanding of how to work with Mass Health to provide dental coverage for people on Mass Health. There are, I believe, DentaQuest, Mass Health, and a lot of other entities, including maybe some of the work happening in the Office of Oral Health, is doing that. But our project, the Oral Health Equity Project, was mostly focused on trying to create bridges to dental care, realizing that, on the other hand, there was going to be a lot of work needed in the dental care space to make sure that those referrals don't bounce back, if you will, or are not handled because of lack of capacity or training. So that, I believe, is some of the work ahead of us, and also some of the work that's been happening for a while now, but that was not really particularly or specifically part of the work of the OHEP.
Thank you so much, everyone. Thank you, Rodrigo, Ralph, and Kate for a great presentation today. I think that we're going to close by having a reminder here that once this presentation's ended, you would expect to receive an email from Emily with a link to all slides and also links to the recording once we complete the whole series. We would like to also acknowledge the participations of all our presenters who have joined us and present and share your expertise here. We have the list of all presenters here. And we also would like to thank you and acknowledge the participations of all our OHELP community partners here, including Holyoke Worcester Public School, all 6 EI sites in Holyoke and Worcester, as well as Family Health Center of Holyoke and Worcester. Thank you also to OHELP team and also our expert to consult us on this project, including Georgia Simpson, Rosie Wagner, and Carrie McGuire. And of course, we also would like to thank our funders, the Office of Minority Health, for making this project successful. So thank you so much, everyone, for participating in our 6th series of the Oral Health Equity Summit. If anyone has any other further questions, feel free to email us or follow us at the website, Department of Public Health, on the OHELP, which is Oral Health Equity Project webpage for more information, as well as for recording and materials that we're going to share later. Thank you, everyone, and enjoy your weekend.
Bye.
Thank you.
Thank you.